Fine, let's move along and we start with the next part of the lecture where we are going to talk about the remaining types of respiratory borne infections. Predominantly, we'll talk about the flu viruses. We'll talk about the diphtheria infections and about pertussis. So let's get along and let's look at the first topic, that is flu. In all the respiratory infections, if you watched the previous module, we talked about 6 C's. What is 6 C? S stands for, we are going to talk about the source. We will talk about the incubation period, the period of communicability, the specific features, immunization, prevention, and control. So in this order, we might cover most of the MCQs and the epidemiological determinants of the related disease. So talking about the source of the infection flu, the source could be clinical cases, or the biggest problem is the subclinical cases. Now what happens in flu is you have massive number of subclinical cases. You can have 50 to 60 to even 70% or even more subclinical cases. So technically you don't know who's spreading the flu. So flu also tends to come in influenza pandemics. Flu pandemics have been reported and they are usually in 7 to 10 year range. Flu pandemics. Why? Because the influenza virus is maintaining itself in the community by use of these subclinical cases. Hence, do we see an iceberg in flu? Of course, there is a big iceberg. Is it a public health problem? It's a massively big public health problem. I think you are relating it to COVID-19 also. So flu viruses are essentially all the influenza related viruses, whereas COVID-19 we will take as a separate module where we'll discuss about these SARS viruses or the CoV-2 viruses. So coming to the influenza related viruses, back again about flu, what is the main reservoir and what are the sources? The reservoir for the flu viruses, these are anything in the world can be a reservoir. We can have various animals or bats or birds which can be the flu virus reservoirs. The source we have already talked, it could be a clinical case or a subclinical case. What is that was your first MCQ. Second MCQ. What is the mode of transmission of this flu virus? I think we all know it's a droplet borne, but you should remember it's an airborne infection as well. It is also gone by the droplet nuclei borne. Next is coming to the next point, that is what is the incubation period. It's fairly low, it's 18 to 72 hours only. What is the period of communicability? It ranges from 1 to 2 days before the onset of symptoms, and it is ranging from 1 to 2 days after the onset of symptoms. So it's fairly shorter incubation period and fairly shorter period of communicability. But the point is that usually these viruses, they change itself. Which are the viruses which are available in the world right now, in the country? At least in India, you should know, we have the H1N1 circulating virus. We also have the H3N2 circulating virus. You know that there is a hemagglutinin and neuraminidase portion. So each influenza virus will have some H number, some N number. So we have the H1N1. You also have the H3N2 which is circulating. We also have the influenza type B viruses. Out of these, which one is the most frequently, which is the most circulating? Still answer is H1N1. It is the most commonly found. It is most circulating virus right now. Circulating virus right now in our country. So this is from the 2019 flu surveillance. There is something called as a flu surveillance. Flu surveillance is happening across the world all the time. So there are some statistical sentinel sites. In these sentinel sites, we are just assessing what type of flu is being circulated across the cities or the states or the globe. The next is we are going to come upon the specific features. Any specific features we would like to remember for our exam? Yes, there is one specific feature, that what is the secondary attack rate. The secondary attack rate of these influenza viruses, it's usually said around 50 to 60% among the non-immune. There is also something called as the reproduction number, basic reproduction number, or the R0 or the effective reproduction number. So technically speaking, R0 is the basic reproduction number, how many people it can give rise to. R0 ranges from 1 to 2 for influenza viruses. It can range during epidemics, it can go up till 3 as well. If you talk about the case fatality rates, that usually 1 to 2% only case fatality rates. It's not a very, very killing type of disease, right? So these are some special features you need to remember for this 6C, SIC, Last is, let's talk about the immunization prevention and control. If you talk about immunization prevention and control for influenza, what is the drug of choice? The drug of choice is oseltamivir. Please remember, oseltamivir is given at the rate of 75 milligrams. It is given as BD dose for treatment, and it is given as OD dose for prophylaxis. It is given as prophylaxis as OD dose, and it is given for treatment as BD dose. These both will be given for 5 days. So that's very simple. Second is, you should also know that there is a vaccine which is available. The vaccine which is available, 2 MCQs. How many types of vaccines are available? We can have 2 vaccines in influenza. We can have a live attenuated vaccine or a killed vaccine. The live attenuated vaccine is a nasal spray. It is not very effective, and there are certain trials which have reported more side effects than benefit on nasal sprays. But of course, all said and done, nasal sprays are available. If you talk about the killed vaccine, these are egg-based vaccines. So that's an important MCQ for you to remember, that influenza vaccine is one of the vaccines which is egg-based. So these all would be egg-based vaccines. So we can have different types of egg-based vaccines. We can have a trivalent egg-based vaccines or a quadrivalent. So technically, we are using a trivalent egg-based vaccines. The trivalent egg-based vaccines are having three serotypes into it. So serotype from Hong Kong, then you have Guangdong strain, and then you have another one is a Washington strain. There is also a quadrivalent vaccine. The quadrivalent vaccine will contain a Phuket strain. These all, what I am telling you, these may change by the time you might be hearing this lecture. So this is what is the 2019 till 20. We are using these strain for vaccinating all the population in the northern hemisphere. So that is what this is called as the northern or the southern hemisphere vaccines. So you have these Hong Kong, Guangdong, Washington, and the Phuket strain, which is being currently used. So anyways, all said and done, the point for you to memorize, you can't go to exam with by forgetting that it's an egg-based vaccine, and that's the reason any person with egg allergy should probably not get a flu vaccine, right? So with that, we finish this topic on flu. So now let us come to the next topic. We'll talk about this 3-star topic, that is diphtheria. 3-star topic, that is diphtheria. So first MCQ, what is the most common age of presentation? 1 to 5 years age is the most common age of presentation of children just before they land up into the school. So let's go ahead and talk about the epidemiological features. You remember, we are going to talk about the 6C, SIC, S and I. 6C features. So S stands for source. So what are the MCQs you need to remember about the source? The source of diphtheria can be 2 things. We can either have a case of diphtheria which is spreading the disease, or we can have a big headache, that is the carrier stage. Now, if you remember from your infectious disease epidemiology, we already talked that in diphtheria, there are healthy carriers, chronic carriers, incubatory carriers. There could be different stages of carriers. Please remember that nasal carriers are more dangerous than the throat carriers. The nasal carriers are more dangerous than the throat carriers. You also know that the carrier stage for diphtheria could be any. We already talked, it could be a chronic carrier. We can have a healthy carrier. We can have incubatory carriers, lot of carrier stages in diphtheria. Do you know that the carrier stage in our country, in a country like India, it has a big range. It could range from as low as 1.5% per 100 population to as big as 5% in the area. That's massive. So the carriers are actually maintaining the infection of diphtheria. They are maintaining that particular level of diphtheria in the community. And as the country progresses, there are chances that the diphtheria percentage carrier may grow, and there is a certain threshold beyond which we get an outbreak of diphtheria. So diphtheria we have started seeing in adult age group. That's the reason that I don't know if you understand or not, but that's the reason to use a TD vaccine instead of the TT vaccine for adult, for pregnancy, and for 10 and 16-year age group. Anyways, coming back to the story, what is the source you need to remember for your exam? You need to remember that it could be a case or a carrier which is spreading. You should also know that the carrier stage in our country is ranging from 0.1 to 5%. And very important, nasal carriers are more important than the throat carriers. Do you also know that immunity to diphtheria, it does not protect from a carrier stage. So carriers can even be people who are immune to diphtheria. So carrier, I'm telling you, is a big headache. So that's the reason that these carriers are important. Next is, still on the source, next is what is the route of transmission or the mode of transmission? How does the infection spread from the carrier to the person or the host, or from the source to the host? So in the chain of transmission, the mode of transmission is primarily the nasopharyngeal secretions. So if it is nasopharyngeal secretions, it will spread through droplets. It will spread through fomites. It can spread through direct contact. So there are a couple of ways diphtheria can be transmitted. So you need to keep in mind all these things. Next is, what we have discussed is the source. Next is, let us talk about the I, that is incubation period. Incubation period for diphtheria you need to remember is 2 to 6 days. 6C. C stands for the communicability. So talking about the communicability or the period of communicability of diphtheria, if the diphtheria is untreated diphtheria may spread. Untreated diphtheria may spread till 14 till 28 days of onset. It may spread. But if you treat it, it will stop spreading. People become non-infectious within 48 hours. So on installation of the antibiotics or of the diphtheria antitoxin, people become non-infectious. However, if left untreated, they become a major source of spread of infection. And you already know that the communicability is more with the carrier stages. So carriers are a big havoc in the country. When will you declare a carrier as non-infectious? A carrier is declared as non-infectious if there are two negative report of culture done at least 24 hours apart. So done at least 1 day apart, two negative cultures, blood cultures, these are considered as negative for diphtheria. Next is, what are the specific features? If you talk about specific features of diphtheria, the concept of secondary attack rate in diphtheria does not apply. Because what is secondary attack rate? It is number of secondary cases which are arising from the primary case. Now what is happening in the community is 5%. We don't know how much percent, but roughly 4-5% of the people are already carrier stages. So they are also spreading. So we don't know if a host is getting what is the secondary attack rate. Are you getting it? So the concept of secondary attack rate is not applicable in case of diphtheria. But yes, you should know what is the case fatality rate if untreated. If untreated, the case fatality rate of diphtheria is a big time high of 10%. So 10% of the population will already die. So secondary attack rate, we don't know. It can range anything from 2%. It is said that some of the researchers, they've tried to do that. It ranges from 2% to 50%, but I don't think that will be an MCQ ever, because the concept, it does not apply to diphtheria. Lastly, we come to the immunization or the vaccines and the prevention and the control aspect of diphtheria. So what are the guidelines we are going to discuss right now? The guidelines for prevention of cases of diphtheria. So in cases of diphtheria, first step, there are a couple of 2-3 things that you need to do. For all cases of diphtheria, we are going to give them diphtheria. First MCQ is, we are going to give them diphtheria antitoxin. Diphtheria antitoxin. This diphtheria antitoxin is given at the rate of 20,000 international units till 100,000 international units, depending on the severity of diphtheria. It is given as 20,000 to 100,000 international units. It can be given as IV or it can be given as IM. Usually IM is given in mild cases, mild to moderate cases, whereas IV would be given for moderate to severe cases, right? So either we give IV or IM, but we are going to give diphtheria antitoxin. This is given after a skin sensitivity test. After a skin sensitivity test. So the DAT is given, DAT is diphtheria antitoxin. Second thing that you need to do is, we are also going to give the antibiotics. That's important. We are giving antibiotics. What are the antibiotics which are drug of choices? We can give penicillin G, or we can give penicillin G, or we can give erythromycin. Erythromycin or penicillin G, these are the drug of choices, and they are to be given for 12 to 14 days minimum. And plus we are also going to do cultures for them, serial cultures, so that we come to know about the response to this thing. Plus, apart from that, in case the person is not immunized, in case the person had not taken any diphtheria vaccine before, we can also think of giving the diphtheria toxoid vaccine, but only in the convalescent phase. Only in the convalescent phase. You don't give diphtheria toxoid while the patient is acutely suffering from diphtheria. Next is what to do with the second module, second protocol is what to do with the carrier stage. If you talk about carrier, simple answer, the drug of choice for eliminating or finishing off the carrier stage is oral erythromycin. Oral erythromycin we can give for a period of 12 to 14 days. Roughly you can remember for a period of 10 days, but practically we are giving for 12 to 14 days, but for your MCQ exam, please remember, it is given for at least 10 days. This is to eliminate the carrier stage. Just for your knowledge that in practical situations, we are giving for 12 to 14 days oral erythromycin. And when do we declare a carrier stage as over? When we get two negative blood culture reports. Two negative culture reports, then we declare the person as non-carrier. And now you should also know what to do with the contacts. So whenever we have a case of diphtheria, we ask them, do you have some contacts? In case we have some contacts, we need to do something with them. So what are the things we are going to do? There are a couple of things you need to remember. This could be a prospective MCQ for you in your exam. So one is, you have talked about the carrier stages, right? So now you're going to talk about the contacts. Contacts is, first is we are going to assess the contact, simple for the clinical features or any signs and symptoms of the disease. Second is, you take the contact and you send these samples for culture of diphtheria. So you have to send these samples for culture of Corynebacterium diphtheria. Third thing that we do along with the culture is we give them antibiotics. It's nothing to get scared of. Antibiotics have to be given to all the contacts of diphtheria. Whatever I am saying is the recent CDC guidelines and the WHO guidelines. Under the National Health Mission, they are not having their own guidelines for diphtheria. We right now are using the CDC guidelines for tracing of contacts and for management of the contacts. There might be discrepancy from what I am saying right now and with the material which is given in the PARC textbook. If you just go and cross-check the reference for that particular year, it is going to date back somewhere 30 years back. So what PARC textbook is writing about is about 30 years old guidelines. Currently in National Health Mission, we don't have separate guidelines for contact of diphtheria. So what we are following is CDC and the WHO guidelines, which were updated in year 2018. So what I'm telling you is the 2018 CDC WHO guidelines, which may differ from your current textbook of PARC. So don't get bothered and don't get confused that Sir told something else, Micromam told something else, and medicine faculty told something else, pediatric told something. It's not like this. I think if you just go and Google about the CDC websites, you will find the same results for the contact tracing. So for contacts of diphtheria, please remember, first is we just assess them for the signs and symptoms. You send the culture for diphtheria, and then you are supposed to give antibiotics. The antibiotic, which are the drug of choices for treatment of contacts or for prevention of disease in the contacts, are two things. You can give them the penicillin G, or we can give them oral erythromycin. This has to be given for 7 to 10 days. Minimum 7 days. If you get one answer, please mark 7 days. So this should be given for 7 to 10 days. In case the person's culture is negative, if the culture is negative, the antibiotics may be stopped once we get a report of negative culture. If the culture is negative, we may stop the antibiotics. But of course, all said and done, in practical areas, in practical situations, I don't think we will be stopping the antibiotics. The antibiotic will still continue for at least for 5 to 7 days so that you complete one course or schedule of the antibiotics. But they don't need to be continued in case we get a negative culture report. Next is, would you like to give them some diphtheria toxoid? So would you give them some toxoid? Yes or no? Yes, we will give them the diphtheria toxoid. Now the MCQ comes, how to give them the diphtheria toxoid. The diphtheria toxoid has to be given based on their immune status. So in case the person, first scenario is, in case the person did not know, that is the best person, he did not know about the status, or in case he had taken less than 3 doses. So in case the person did not know or they have taken less than 3 doses, what are you going to do? Give them one diphtheria toxoid and complete the series now. Complete the series. How many types of, what is the regime for diphtheria that we give? We give 2 primary, we give 3 primary doses and we give 2 booster doses. How many doses? We give 6, 10, 14 plus 16, 24 and 5, 6 years. So it is 3 primary doses. The current strategy that we are following is 3 primary plus 2 booster dose for diphtheria, right? So for diphtheria toxoid, you're supposed to give at least 3 primary doses and complete the series. Next is, that is for unknown cases. Next is, let us say a person, I know about my diphtheria status. Let us say I have already taken more than 3 doses previously and the last dose was taken more than 5 years ago. More than 5 years ago. So if the last dose was taken more than 5 years ago, in that situation, we are going to give only one diphtheria toxoid booster dose. Give a single one diphtheria toxoid booster dose. And in case the person had taken, third scenario, more than 3 doses and within the last dose was within 5 years, recent 5 years. In those cases, no vaccine is required. But in case if it's a child and was scheduled to get another diphtheria or whatever vaccine, so please continue the NIS. Continue the national immunization schedule and give vaccine. Give vaccine whatever is pending or due. Give vaccine which is due right now. So whatever vaccine is due, you give it at that time. You don't need to add any other vaccine. If the child had already taken more than 3 doses and the last dose was within 5 years. So that's the simple answer for management of the contact cases. Next is a couple of questions you might get on DPT vaccine. Diphtheria, pertussis, tetanus vaccine. Currently, we have a pentavalent vaccine. Pentavalent contains the D, P and T. Plus it also contains H influenza B. Plus it also contains the hepatitis B. The common answer for all these things is that the side effect you need to remember, the side effect for diphtheria, pertussis toxoid or the pentavalent vaccine could be neurological problems. Neurological problems. These neurological problems are primarily because of the pertussis component. This DPT is always given, or pentavalent is always given as 0.5 ml intramuscular injection given in the anterolateral thigh. Anterolateral thigh. Which side? Left or the right? It is given on the left thigh. So 0.5 ml intramuscular anterolateral thigh is the schedule, and the schedule is we giving 3 primary plus 2 booster doses. Please remember, DPT vaccine or the pentavalent vaccine, all these vaccines, these are freeze sensitive. These are freeze sensitive vaccines, so never put the vaccine on the ice pack. So don't put the vaccine on the ice pack. That is a general rule. Do not allow them to freeze. Please remember that for these freeze sensitive vaccines, we also have a shake test. Shake test is there. And now for adults, we now have started, instead of the TT vaccines, we have the TD vaccine, which I think you all know. The smaller D stands for the low dose diphtheria vaccine. So this TD is given to all adults in case of people who are pregnant, females who are pregnant. So you're giving them 2 doses, TD1 and the TD2. And in case of children aged 10 years and 16 years, we have replaced TT, that is tetanus toxoid, with the diphtheria toxoid, tetanus and diphtheria toxoid. So with that, you cover, there's a couple of questions which may come on diphtheria, and specifically important for your MCQ exams, I'm saying it again, is you need to remember about the contacts. Couple of times they will ask you question on contacts, they will ask you questions on carrier stages and how to prevent, control and immunize a person in cases of diphtheria. Next, always a disease which is in conjugation, we always study with diphtheria, is pertussis. Pertussis, again, same issues. What is the most common age of presentation? Most common age is in children less than 5 years. Pertussis is also called as a 100-day cough. WHOOPING, whooping cough. So these are a couple of things you need to know about pertussis. Let us talk about the 6C. Let's talk about the 6C protocol. The source of pertussis is primarily a case of pertussis. That's interesting to know that the source of pertussis is only a human. Human can only be the case of pertussis, and there we do not know any subclinical cases or carrier stages in pertussis. So humans are the only known cases, and the only source of pertussis would be a case of pertussis. What is the mode of transmission? Or how does pertussis spread? It spreads via droplets, or it can spread via fomites. What is a fomite? I think we've had a word before as well, fomite. Fomite is any pen, pencil, articles. These are non-living things on which the infectious agent can come and sit. So this pen is a fomite, right? So we can have the source would be a human, which is the only source. It is a case, and human is the only case. Please remember, there are no subclinical cases. No subclinical cases occur in pertussis. Next is, we talk about the I component. So we have talked S. Next is I. I is incubation period, ranges from 7 to 14 days. Nothing very special. Next is, if you talk about the communicability period or the period of communicability, you need to understand that, let us say in this timeline, there is an exposure to pertussis agent, Bordetella pertussis. Then there is an incubation period. Let us say that the incubation period goes on till 7 to 14 days. What are the clinical stages? The clinical stages in pertussis would be ranging from catarrhal stage, then it will move on to a paroxysmal stage. Then it will move on to a convalescent stage. The catarrhal stage is roughly for 10 days. Okay. The paroxysmal stage would roughly range from 2 to 3 weeks. That's a long time. And convalescent is 1 to 2 weeks. So roughly speaking, it's like 2 weeks, 3 weeks, 5 weeks, and another 2 weeks, 7 weeks. Right? So more than 7 weeks, this is just the minimum number we are taking. So that's the reason we say it's a 100-day cough. It just keeps on hanging. So this is what is the timeline. So when is the patient communicable? It's important and interesting to understand as well. The patient, if you understand this clinical features, it will be easy for me to write down that the patient is communicable 1 week after exposure. Leave the incubation period. So as the catarrhal stage would start, as the first sneezing on those things will start, the patient becomes infective they start throwing the Bordetella pertussis. So the patient is infective from 1 week after exposure. That is not in the incubation period, exposure. That's interesting, till 3 weeks after the paroxysmal stage. So in the whole paroxysmal stage, the patient is infective. So till 3 weeks of paroxysmal stage. right? So that's interesting that this Bordetella pertussis or pertussis disease has such a long communicable period. When is it maximum communicable? Please remember, it is maximum communicable in the paroxysmal stage. This has been so many times MCQ that the period of communicability is ranging very high. It ranges from 1 week after the onset of after the entry of infection, or after the it just starts from the onset of disease, and it ranges till the catarrhal stage, goes through the paroxysmal stage. It is highest, or the maximum communicability is in the early part of paroxysmal stage. Early part of paroxysmal stage is the maximum period of communicability. So with that, we have done SI. Sources done, incubation period, communicability. Let us talk about some of the specific features of Bordetella pertussis or pertussis disease. The specific feature would be something interesting to you, that again, in this, the case fatality rate is not very high, but it still ranges from 5 to 6%. The secondary rate is important. It is again 90% in unimmunized. So if we have a child who's not taken a DPT vaccine, and in case there is a pertussis case, there is 90% chance that this patient is going to develop the pertussis. So that's the problem. Last is immunization, 6C. So last is immunization and prevention and control. So what about the immunization? There is only one immunization that is available, that is the DPT vaccine, which we already talked just now in diphtheria. Just 2-3 points just to reconfirm that you all remember, you are ready for your exam. You should know that the pertussis component is most responsible for the neurological complications. DPT vaccine is contraindicated in children with seizure disorders or progressive neurological deficits. It is not given in those cases. It is more associated with neurological disorders. It is more associated with crying, with screaming, with unconsolable cry, with screaming. What you must be doing right now, because it's the end of the lecture, right? So what you must be doing right now, that's the same side effects of DPT: crying, excessive crying and screaming and getting irritable child. Then there is hypotonic, hyporesponsive states, and the child is irritable. So all these things are there in DPT. Please remember, the drug of choice for pertussis is erythromycin. Erythromycin is the drug of choice for pertussis. So with that, we finish this topic on flu and diphtheria and pertussis. Thank you so much for watching these respiratory infections.